Hello and welcome to the Evidence-Based Urgent Care Urgentology Podcast. I'm Joe Toscano. I am on the editorial board of Evidence-Based Urgent Care and also the senior research editor for the sister EB Medicine publication, Emergency Medicine Practice.
And I'm Tracy Davidoff. I'm the editor-in-chief of Evidence-Based Urgent Care. Joe and I have been involved in urgent care practice and education for many years, and we're really excited to bring to you this program from EB Medicine, the Evidence-Based Urgentology Podcast. Our goal for this podcast is to review one of the recent issues of evidence-based urgent care and highlight some of the important things that have come out of that issue, the learning points, and potentially practice-changing information from the piece.
We hope that the podcast will be valuable in and of itself, but it'll also whet your appetite to delve more deeply into the issue, to hone your practice, and even get some CME credit.
And even if you've read the issue already, Joe and I hope to reinforce the important points and solidify important concepts to improve your learning as a result.
If you create an account at ebmedicine.net, you can subscribe and purchase the issue. You can check out the interactive clinical pathways they have there, and you can get up to 4 hours of CME credit for completing this one issue. Hey, you've already started your CME journey by listening in.
And you can also subscribe for a full year so you won't miss anything. At the regular price, that's a great value. Be on the lookout for occasional promos, sales, and special offers to make it that much easier.
Welcome, everyone. We're here to record the podcast, the Evidence-Based Urgentology Podcast, for the June issue, Evaluation and Management of Wrist Injuries in an Urgent Care Setting.
Our author for this episode is Adam Churi. I believe I'm pronouncing that correctly. PIC, who's an assistant professor at the School of Physician Assistant Studies at the Pacific University in Hillsboro, Oregon.
And our peer reviewers, Lindsay Watkins, we know her, PAC, FCUCM, Advanced Practitioner Lead at Northwell Health, Go Health, Urgent Care in New York, and Martha Williams, Doctor of Health Science, MS, PAC, Independent Physician Assistant at MedExpress Urgent Care in Harrisonburg, Virginia. And she is actually also a clinical content specialist for Urgent Care Association.
We know both of those quite well. They both work with us at UCA and the CUCM, and I'm happy that they do a lot of work for us too here at EB Medicine.
It's great to see their names in print.
Absolutely. So we have a bunch of promos this month. There's a June birthday sale. I guess this is coming out in June.
Mm-hmm.
Starts June 1st, which is 26% off anything because it's our 26th birthday. Well, not our 26th birthday, but EB Medicine's 26th birthday. 26% off the subscriptions, the courses, LLSAs, and the coupon code for that is BDAY26. That's birthday B-Day 26. It's our birthday, but you get the free gift and help us celebrate our birthday. We also have the new and improved laceration course, and I got to tell you, this thing is phenomenal. There are some videos in there that would knock your socks off. Lots of new extra content and really in-depth. Everybody can learn something from this, even seasoned people like us. There is full access to the new course, which comes out on June 10th, and you can find that on our website. I am not reading that whole big long website thing. Just go to ebmedicine.net and look for the laceration course. And then we also have safeguarding charting, which was done by me. This is document support that'll stand up in court. You get 4 CME credits for that. And it's a long course. It's about 4 hours. But initially we go through all about medical malpractice and how you shouldn't fear it, but you should definitely respect it, what you need to do to document, to protect yourself. And then we go through each chief complaint. We go through 10 separate chief complaints and talk about what you need to document to protect yourself against the worst case scenario and what you need to do to write as far as your medical decision making is concerned for a couple of things, one for charting purposes and for billing purposes, but mainly to say, hey, I thought about all the worst case scenarios and I ruled them out because of X, Y, and Z. So this is really a fantastic course. It came out of a lecture that I gave at UCA a few years ago. And it just morphed into this amazing 4-hour course. And my friend Jeff Wells, who's a retired emergency physician, but now doing just legal consulting, also did the medical malpractice piece on this. And it's a great course if you want to check it out. It's also on the website.
Definitely good stuff. And you get CME credit for the time that you spend on it also. Tracy, this issue was a really good review of some bread and butter stuff, but there were some important points. Do you want to start off by talking about the range of injuries and conditions involved in the wrist that we might see walking into the clinic?
Yeah, and me and Joe say this every time we do this podcast. Reviewing this stuff is great education for us too. It reinforces what we already know, but it points out some of the things that are super important that maybe we've been taking for granted. I always find something new in these episodes, and this is great. So regarding risks, we've beat forearms to death over the past couple episodes, but we're going to go a little lower and we're going to talk about wrist. Majority of the wrist injuries we're going to see in urgent care, they're pretty much sprains, fractures. Your worst case scenario here is going to be a dislocation or an open fracture. And most wrist injuries are due to falls, due to the old famous swoosh or fall on an outstretched wrist. And
Mhm.
most commonly, out of the injuries that you see that are fractured are a distal radius and a scaphoid fracture. Those are the ones you're going to see the most. We're just going to go over some of the most common here. We're not going to do really a comprehensive deep dive here. We're going to do the most common and the most commonly missed. Word question alert, scaphoid fractures, anatomical snuff box. We all learned in anatomy when we were in school where that is. It's that little area in the wrist. If you move your thumb around and make that tendon pop up, we can find that little triangle in there. So you want to be very wary about tenderness in this spot and document it. Don't forget, always document snuff box tenderness, or especially after a foosh. Always be suspicious if you're palpating that. The x-ray can be really negative early on. So if the mechanism is there and the snuff box tenderness is there, treat it like a fracture until proven otherwise. You're going to splint it. You're going to repeat the x-ray. You can do that in your clinic, or you can send it to our ortho colleagues. The point is you really want to do some close follow-up until the injury is ruled in or out. Failure to diagnose or treat a scaphoid fracture appropriately can result in osteoarthritis, chronic pain, loss of function, usually due to avascular necrosis of the fractured segment. Blood supply here is really kind of crummy. So if you have a fracture, the one little piece of the bone can lose its blood supply and then basically die and get osteonecrosis. And that results in all this complications. You don't want to miss this one. This one's going to hurt you and come back to bite you if you miss it. Second most common is the distal radius fracture. If it's minor, it can be minimally displaced. You can just see a little tiny fracture line through it. But these can run all the way from minimally displaced to really significantly displaced. So you want to be on the lookout for displacement because that really alters your management, and these need to be reduced in a timely fashion. Maybe not right away, but pretty significant displacement really needs to be reduced earlier rather than later. Nisha talks about hematoma blocks for this, and we're going to talk about that a little bit later. Do we have to send all these people to ED for reduction? Well, sometimes. If you can't reduce it yourself, or if it's something that's really significantly displaced and you're worried about neurovascular compromise, then yeah, probably ED. But if it's something that's minimally or only moderately displaced and the patient's pretty comfortable and you're pretty sure you can get them into see ortho in a timely fashion, then you don't necessarily have to send these to the ED. Another board question here, hamate bone fractures. So these are usually due to a direct blow to the wrist. The patient's either hit by a baseball. When I was still in New York, we used to see people getting hit with lacrosse sticks in the wrist all the time. I could never figure out why, but girls had to wear like all sorts of protection, but boys did not. They would get whacked in the wrist all the time with the lacrosse stick, which is really quite hard. And the lacrosse ball, which is even harder, really harder than a baseball. So if you get whacked in the wrist with that, it can result in a hamate bone fracture. Ulnar side of the wrist in that area, just distal to the ulnar styloid process. And why this is so important, well, one, you don't want to miss fracture, but the fracture fragment can impinge on the ulnar nerve and the flexor tendons to the fourth and fifth fingers, causing some loss of function in that area. Loss of function in the hand equals lawsuit. If you miss it, you always want to make sure that you catch that one. Other don't miss things in the wrist, lunate fractures and lunate dislocations caused by a foosh, but this time you're due to forceful hyperextension with ulnar deviation at the same time. That takes that lunate, and if we all remember, it kind of looked like a teacup holding your wrist in place there. So when you fall in that way, it causes the bone to shift and it dislocates. The money shot on this one is a lateral x-ray, and I got to tell you, the ones that I've seen, the oblique view and the PA view are normal. You look at that, maybe you get a sense of something not quite right here, but they look normal until you look at that lateral and you're like, oh, there's that spilled teacup. That lunate is not where it's supposed to be.
That's why it's so swollen.
Yeah, exactly. And I've seen ones that are not that swollen, but don't miss those. Very important to make sure you catch those. That's very important to look at all three views. And then our scapholunate dissociation, also a board question. Similar mechanism to the lunate fracture where the patient falls on a hyperextended wrist, and that causes separation of the carpal bones due to rupture of the ligaments in that area. It basically is a really bad sprain. It's not really a fracture, but this can result in permanent disability if it's not treated here. And our buzzword here is the Terry Thomas sign. I don't remember Terry Thomas because, that's even before my time, and, we're not exactly young. But Terry Thomas apparently was a famous actor, and he had a huge gap between his front teeth. And this simulates the gap that you see between the scaphoid and the lunate on x-ray. So if you see more than a 4 millimeter span between the scaphoid and the lunate on your PA view of the x-ray, that's called the Terry Thomas sign, and that indicates that patient has scapholunate dissociation. Make sure these people have ortho follow-up because, again, this can result in some arthritis and loss of function, and we don't want that to happen. I'm going to mention some overuse, really just carpal tunnel that we're talking about here. We're all pretty good at that. I think we see a fair amount of that, especially if you do some OCMED. It's a clinical diagnosis in the urgent care. We're not going to be doing MRIs on these people. We can pretty much tell just by what they tell us. And all we can really do in urgent care is provide them some splints to wear mostly at night and recommend some conservative care. But if they don't get better, you probably want them to go see a hand specialist to figure out a little more what the ultimate care for that should be. And then arthritis, people do come in with arthritis either because they have RA or PSA, and they may need some pain control, get them what they need, and then send them back to the PCP. I just want to touch on ganglion cysts. I love ganglion cysts. They're the coolest thing, but people walk in and they think they have some tumor growing on their arm, but they actually are a fluid-filled outpouching of the tendon sheath, and they usually occur on the dorsum of the wrist. They're more common in females age 20 to 40. They're kind of distressing to look at, and you can traumatize them. If it's in an area where it can rub and get traumatized, or, people can bang them against things and they can become inflamed. Generally, a ganglion cyst is not something that's painful, and they can actually go away all by themselves. The treatment of choice these days is now surgical removal. Other treatments that have been done relatively unsuccessfully in the past is draining them with a needle or injecting steroids into them, but evidence has shown that doesn't really pan out that much. In the really old days, we used to smash them with the book. We used to say that's what Harrison's was really good for, or that surgical text that I can't remember a name for. And for all you young people, this is not an urban legend. We used to actually do this. I remember doing it as a student in ortho rotation. We'd get our Harrisons out and we'd just smash those things with a book. Anybody use textbooks anymore? I'm not really sure.
No.
But yeah, that was really effective because it would break the cyst, the fluid would come out of it, it would get all inflamed, it would scar down, and then it would be gone. But I guess, that's not politically correct to smash people with textbooks in. So we do them surgically. So Joe, ortho and wrist, pretty straightforward. Do we really need to take much of a history? They fell down and went boom and their wrist is broken. What do we really need to know? Anything?
Yeah, well, it's the starting point anyway. After your open-ended question, like, what the heck happened to your wrist? You had talked about a number of mechanism of injuries that sometimes if the patient can remember it, and most of the time they can, you can begin to suspect certain injuries, hone in on your physical exam, and then spend a little extra time looking at what that classic injury associated with a mechanism of injury is going to be on your x-ray, because wrist x-rays can be a little tricky to read. A lot of bones kind of all in the same compact area there. So sometimes if you have a clue based on the mechanism, Fuchs is the most common, but sometimes people will fall on a flexed wrist or the ulnar side of their wrist or the radial side of their wrist. So knowing that ahead of time can help you focus the rest of your history and exam. With injuries, most of the time patients are going to have the acute onset of pain. With subacute onset of pain, you're going to think maybe a little bit more about an overuse type injury or maybe arthritis as the cause. Wrists, we use our hands for so much that getting a work history and occupational history is important in your history taking. If somebody spent a lot of time at desk work or using tools or vibratory tools, a little bit higher risk of carpal tunnel with vibration or tight gripping through the workday. Also desk work. We don't necessarily have to do it for our documentation the way we used to, but the PQRST, I guess, when did this happen? Now it's old carts, OLDCERTS. That's great. It actually covers more the onset, the duration, the characteristics, the aggravating factors, and that kind of thing. So it might even be a better mnemonic for what we need to ask. And again, it just can help you understand more about what the diagnosis could be. Neurovascular, definitely important. So you want to ask about associated weakness or tingling. You can examine for that as well, but you want to ask if the patient's aware of weakness with grip or wrist movements, or any tingling or numbness may clue you into neurovascular or neural compromise from an acute trauma, or maybe a primary problem like carpal tunnel or compression of the ulnar radial nerve, as the primary issue. Just in general, you're going to want to know if there's any prior injuries that may affect your interpretation of the plain films or surgery on the wrist. All of those things are important, similar to other orthopedic injuries. Hey, what did you think about the author's discussion of the diagnostic testing and some of the potential pitfalls?
Pretty good. Pretty much covered everything. We always talk, and I reiterate this in every single one of these orthopedic talks that we do.
Yeah.
Gotta get the good x-rays. Your x-ray is substandard or not positioned correctly, you're absolutely going to miss something, especially in the wrist, because, as Joe alluded to a little bit earlier, you got a bunch of bones in there that all overlap each other. It's kind of like a little party in there in your wrist. So if you don't get those positioned exactly right, you're going to miss something. So I am not afraid to tell my x-ray tech, look, I need it better, do it again. I don't want patients to be radiated more than they have to be, but I also need to be able to interpret those films appropriately.
You want it to count.
Exactly. And the radiologist should do the same. If the radiologist is not happy with the views, they should do the same. Overlapping carpal bones may make interpretation difficult. So really, if you think there's a fracture clinically based on mechanism of injury and based on your physical exam findings, and your x-ray doesn't bear that out, you've got to assume that there's probably something in there that you're just not seeing. So you want to make sure that you have the patient follow up for a repeat in a couple of days or even a couple of weeks, or follow up with ortho just to confirm that there is in fact no fracture there. Some things can be really subtle and don't show up initially until you get some inflammatory reaction or some separation of bone that you can now see it. So always make sure that it be suspicious. Don't say, oh, x-ray's negative, you're all good. Make sure they have some adequate follow-up. MRI might also be necessary to rule out some occult injuries, just something else to confirm whether or not there is something there or not if you really have that high index of suspicion. CT is also of value here, especially for those acute injuries, for a couple reasons. One, to rule out occult injuries, but also to figure out morphology prior to repair. Surgeons do this sometimes just to see which bone is where and how to plan their procedure and how they're going to go about doing it. Also helpful for ruling out any instability or dislocation that might be subtle on x-rays. MRI also good for occult fractures and especially for sprains that aren't improving. I always thought sprains 6 to 8 weeks. You give it that long. But the trend is changing. Now the trend is saying for MRI, maybe we should do these sooner rather than later. For things like our scapholunate dissociation and other tendinous injuries, outcomes are actually better if these are repaired sooner rather than later. So if you're doing follow-up on patients or if you're doing some OCMED and you follow them more regularly, if they're not getting better in about 2 weeks from their wrist sprain, they're still having significant discomfort and significant loss of function, you want to consider an MRI to evaluate the ligament and tendon damage. So if you see that wrist 2 weeks out, consider doing an MRI, or if you can't do it or you can't get it approved or whatever, refer them to ortho and let them do it if you can't order it themselves. Other pitfalls we talked about, the scaphoid and the lunate, that spilled cup, and of course the teratonis sign. So Joe, what did you like about how the authors described physical exam when it came to the wrist?
Yeah, well, I think physical exam is a big part for me in honing in on the wrist. You got that x-ray with all the 8 bones, and you got the 5 metacarpals, the 8 wrist bones, and then the distal radius and ulna. And I really like to find out where the person is hurting, and I'll focus my inspection of the x-ray on that area, especially or even more, kind of having an idea what those bones, as you're looking through the skin, where they are, their location and their orientation to each other, I think is important. Other parts of inspection, you had alluded to it, and we want to look for swelling, obvious deformities. I mean, if something's really out of whack, you're going to really suspect a fracture. But just because there's not that much swelling doesn't mean there isn't. The more swelling there is, the more likely it is. But you really have to be careful, even if there's none. You're going to want to look for erythema and wounds as well. Open fractures may manifest as wounds. Infections in the wrist, which the issue didn't talk about too much. I don't think it's as common as other joints. But if you're worried that there's an infection there, the wound may be the telltale sign. Know your landmarks for palpation. After that, you're going to want to test range of motion, active and passive. Person has a fracture, they're not really going to be able to move that much themselves, and you probably don't want to move them that much either. So if you have an inkling of that based on their history in the early parts of your exam, not super important. I find it more important with overuse injuries and tendonitis to check the range of motion. I like the extra time and the images they spent on the neuro exam. The wrist has 3 nerves crossing it. It's got the ulnar, the median nerve, and the radial nerves, and they each go to kind of pretty well demarcated parts of the hand. So you can test for sensory loss in those areas to know if the nerves have either been involved in an injury or maybe they're the primary problem because the person has radial tunnel syndrome or carpal tunnel syndrome or compression of the ulnar nerve at Guillen's canal. And you can pin that out based on sensory loss. And then also there's some distinct motor exams that are important to check as well that can clue you into one of those nerves being either injured or part of the problem. We have special tests that we can use at the wrist, like Phelan's and Tennell's. They're not super sensitive, but they can help you establish some suspicion of whether there might be something like carpal tunnel going on, or again, tapping over where the radial nerve or the ulnar nerve traverse the wrist. You can get clued into problems with those nerves as well. Hey, Trace, what would you emphasize about treating fractures, even displaced ones? They talk about using a hematoma block. Have you ever done that in urgent care?
I do. I like hematoma block. They're awesome. And I actually got to experience in one myself when I broke my wrist a year and a half ago. Yeah, that was fun. I always get hurt coming back from UCA activities. I don't really know why, but yeah, I did a foosh myself and I had a lovely displaced distal radius fracture and got to experience the hematoma block. And man, that was fantastic. I went from this is killing me to I was really barely hurts at all in matter. But yeah, I do them. They're great, not just for reduction, but even for pain control. They're really super easy to do. There's really no risk of infection if you clean and prepare properly. And I was always worried about that when I first started doing this. Oh my God, what if we end up with a joint infection because I stuck a needle into a broken joint? But the studies really don't bear that out. It doesn't really happen. It eliminates the need for any sedation. I remember we used to do some conscious sedation to try to reduce these, but if you do the hematoma block, no more conscious sedation that's necessary. And if you're able to reduce it, you can actually avoid an ED visit if you can reduce that fracture yourself. So super easy. You take a syringe with 10 to 15 cc's of lino, either 1 or 2%, doesn't really matter. Probably wouldn't use the epi here. You go directly at a 90-degree angle right into the center of the dorsum of the wrist. You slowly retract your plunger until you get some blood, and then you inject slowly. I like to use some topical ethylchloride spray first to anesthetize the skin, which is more comfortable for the patients. Trick here, like all other anesthesia that a lot of people don't do, is give it some time to do its thing. I like to go walk away and see another patient and come back in 10 or 15 minutes. Now they're all nice and numb. And you can easily manipulate those bones into the right position. After reduction, you're going to want to use some sort of splint to keep it in place. Probably a volar splint is more than adequate as long as it's well secured. And then repeat the x-ray to confirm that the reduction was successful, or at least partially successful. You want it back as close as you can, but if you can't get it all the way in, that's okay. Our ortho friends can do that. Don't forget about checking for neurovascularly intactness after you're done, and make sure you document that. Other things to emphasize here with treatment and disposition: open fractures, all of those, you want to send those to the ED. Any neurovascular compromise can be permanent pretty quickly, so you want to make sure those get evaluated in the ED. Severe pain that you can't control for whatever reason, you want to send to the ED. Really severe displacement that you're not able to reduce, that also needs ED and emergent orthopedic evaluation. And safety. A lot of these will occur in elderly people. They will not be safe if they're living alone. They use a walker and now their arm is splinted. So if they can't manage to feed themselves, get to the bathroom, and take care of their ADLs, they need to go to rehab or some sort of nursing facility. Obviously, that's not something we can arrange from urgent care. I hate to send those people to the ED for social reasons, but sometimes you just have to do that.
Yeah.
Everything else that's not going to the ED, real simple. You can splint it and follow up as an outpatient. We talked about this in forearms. Make friends with your local orthopedist. Have a relationship and an arrangement with them that they'll see your patients in a day or two after you discharge them. During normal business hours, you can even give them a call. But if not, you can make sure that the patient calls the next day and tell them, hey, I was seeing in urgent care. They told me I need to be seen within a day or two. Can you get me in? And they're usually really good about doing that, especially if there's an acute injury and they know that the patient was previously seen in urgent care. If they can't get in to see ortho in a timely fashion, make sure you have a contingency plan and tell them about it and document it. Look, if you call ortho tomorrow and they say, hey, we're on vacation, we'll see you in 3 weeks, that's not good enough. The patient has to know that. Either call a different ortho or get yourself to the ED for definitive care, because reduction is time dependent. If it doesn't get reduced in a timely fashion, those bones will start to heal. Then you're going to end up with a world of hurt, and we're going to have to take them to the OR and re-break them and thin them or whatever it is they need to do to get those bones back in the right position. Make sure that you have complete function once you're healed. So what did you think about splinting, about what they said in the article regarding the splinting?
Yeah. Hey, I'll talk about it in a second. I wanted to bring up something about hematoma blocks. It's not something I've done since the beginning. Probably started to do them about 7 or 8 years ago. And the first couple of times I did it was in the ED, and I used ultrasound. It's really cool. You can see that hematoma and get right into it. And you have to have blood return. Just sticking in anesthetic around the wrist and around the fracture doesn't help. That hematoma is continuous with the fracture surface. So if you get good blood return, you put the anesthetic in and it will bathe the hematoma, but more importantly, it'll go down to where the hematoma came from, which is the fracture itself. And it's really kind of a game changer. You can get these wrists in better position, put them in a splint, and save the patient an ED visit, not really have to do any sedation or anything like that. So yeah, I think it's something we should all become more proficient with. So once you do your reduction, if you need to, or if you don't, splinting the patient is going to be important. Of the splints that we would make ourselves, and even the Velcro ones, they tend to be similar to this. We have 3 main choices. We got our volar splint, which is one-sided, going along the palm side of the fingers and the hand and the wrist and the forearm. A sugar tong, which is basically that plus something on the dorsal side. And most of the time they're connected to each other with a little U shape that occurs at the elbow. But you can also do a reverse sugar tong. Basically, it's a little bit more supportive. You have basically now something on both sides of the forearm supporting your wrist fracture. If you have a more unstable injury, then it's going to be a little bit better choice. And then the spica splint, which goes along the radial aspect of the forearm and the wrist and into the thumb. And it's not really enough to immobilize most injuries in general of the wrist, but it's your perfect splint for if you suspect something on the scaphoid or if you happen to have something in that first metacarpal, because the important thing that it does is it immobilizes the thumb. If you were to just do a volar or even a sugar tong splint and you have a scaphoid fracture and your thumb can move around, that can actually displace those scaphoid fragments and give you that worse outcome because of avascular necrosis that you talked about. There's one other splint that crosses the wrist called the ulnar gutter splint. It's more for hand type things or maybe a kind of a forearm sort of thing. It's not really mentioned for wrist things, and I don't find it super useful except maybe for boxers and now they're saying you don't even need to do it for boxers. You can just do a softer type splint. But that's that fourth splint. It crosses the wrist, but not necessarily useful for wrist problems itself. The author discusses the use of wraps and Velcro braces as well. And fractures, you're going to need to immobilize anything that's unstable that can move out of place. But for tendonitis and most other problems, and even some, we didn't really talk specifically about pediatrics, but the movement for Torus fractures or Salter-Harris 1 type injuries is not to completely immobilize them, but using something like a Velcro splint, or even for Torus fractures, something that's softer like an ACE wrap is generally going to be okay. It's going to support the wrist, but not necessarily completely immobilize it. And particularly for tendonitis, immobilizing it can cause the wrist to kind of stiffen up. And what you basically want is something that's going to support it that could be used on an as-needed basis and not something that the patient's going to be reluctant to take off. One of the other entities that the issue talked about is carpal tunnel syndrome and night bracing. There's some evidence here. Night bracing has been shown to benefit patients with carpal tunnel. Every so often, don't you wake up and you find that your wrist is like super flexed or in a weird position, and we just have no awareness of that at night. And it's felt to be one of the things that doesn't necessarily cause carpal tunnel syndrome, but can aggravate it. So I remember the first time I was reading about that thinking, why would you want to brace the wrist at night for carpal tunnel? But it prevents that odd positioning that can occur when we're unaware. During the day, you're aware of stuff, but at night, you're not. And it's one of those things that can be helpful. And a Velcro splint for that is reasonable, something that the patient can take on and off. And that's pretty much it for splinting. What about pain management? What are some of the important points we need to keep in mind for that, Trace?
Do it.
Yeah.
Don't forget about pain management. These things hurt. I got to tell you, breaking a wrist, that did not feel very good, especially when it's your dominant hand and now you can't do anything. You can't feed yourself or anything else, and it hurts every time you try to accidentally do it because you're not used to not having a hand. So splinting and icing, they go a really long way. I find people come in without any sort of splint or anything, and their wrist is flapping around in the breeze. Of course, it's going to hurt. So if we just splint it to prevent it from moving, that goes a long way in helping with pain. Ice also helps a long way. NSAIDs probably going to be the mainstay of treatment here, but remember, don't forget to watch out for those contraindications, people with renal disorder, people with any sort of GI bleeding issue, people that have allergies to NSAIDs, and don't forget about the gastric bypass reduction surgery folks. They should not be getting NSAIDs because of the increased risk of bleeding. Topicals, the article actually kind of mentions topicals. Not a huge fan for wrist fractures. Maybe for a sprain or for arthritis, I think the topical diclofenac is relatively effective, but I don't think it's going to do a dang thing if you have a wrist fracture, especially if you now splint it. You can't put a topical on something. So case by case basis, let's just say. Opioids only for severe pain. If NSAIDs or other measures don't work, then you can go to your opioids if you absolutely have to. But like I said, severe fractures, those things hurt. If it's a displaced radial fracture, you may have to give them a few days of opioids. Don't forget the contraindications here and make sure the patients know that they're going to get sleepy. They may have some respiratory depression and the addiction potential. You may want to skip these in elderly due to the increased risk of falls and sedation. And if you do decide to give the opioids, only give a few days supply. Broken bones is probably the one thing that I usually always feel like maybe they should have an opioid. I pretty much don't give them at all anymore for most conditions, but fractures, you may want to consider for that. Oh, boy. Okay. Let's talk about risk management. There were a lot of high points in the risk management pitfalls. I don't really want to go over all of them because of the interest in time, but let's talk about a couple. What were your favorite?
I like the two that talked about medicines, namely, you had touched on this, but prescribing opioids with care for the elderly, and also to be careful with NSAIDs. They're over-the-counter medicines, but there are plenty of warnings on there for people not to use them in certain situations. And when we're prescribing them, we need to keep those in mind as well. Tylenol, really very safe, unfortunately, not super good for moderate to severe pain. But I think, like you said, you got to balance the need and make sure the patients are counseled. And I will, particularly for opioids, in those times where I feel like they need them, ask the patient if they've taken and tolerated them before, have them start dosing low, and then just be careful. It's not like an automatic thing. And so basically, that careful approach and shared decision-making is important in that situation. Probably spend more time talking about that than I do other aspects of the care. What was your favorite risk management, Pearl?
I would say the X-ray ones. One of my big shticks here is a negative X-ray does not rule out a scaphoid fracture. So many times I see people say, oh, well, the X-ray's negative, you're all good. You're not necessarily all good with a wrist, especially with that scaphoid. You need to be really diligent about this because of the bad outcomes if they're missed. Also, there was a risk management pitfall about innervation and circulation. So it's so important in wrist and hands to make sure that you document function. People need their hands to work properly, or it may be really devastating from a functional standpoint. I mean, more important if you're a pianist for a living, but that's what separates us from the animals is being able to grip and use our thumbs and use our hands properly. So if you have a wrist injury that causes some neurologic function or some tendon disruption and messes up the hand, that's not good. So when you do your physical exam, you really need to make sure that you're really diligent. Asking the patient to grip your hand is just really not enough. My standard exam and standard documentation is I have this thing where I say normal, passive, active, and against resistance in all planes. So that means that you make sure everything works in all directions, just you moving it around, having them move it around, but then doing that extra step and checking that against resistance, because some really subtle injuries can only show you that they're there when you try to have the patient straight test. And remember, fingers and wrists are not just flexion and extension. They also move olarly and radially. So sometimes I'll just have patients make circles with their wrists, and that way I know that it's working in all directions. And people don't always check this, but definitely important. So neurovascular compromise, you want to make sure that they've got some good capillary refill and you've got some good sensation at the ends of all your fingers. Probably do this before your hematoma block, right? Make sure that the sensation is all intact. And if there is any loss of function, they really need some urgent evaluation, especially if your cause is not obvious. All right. So any closing thoughts?
Yeah, I think we just need to keep in mind the bony, vascular, and nerve anatomy around the wrist. It's actually not hard to memorize and important for all kinds of reasons. The X-ray pitfalls, I think we need to keep in mind, just like you said. And if there are no indications to send the patient to the ER and your X-rays look good, but you're still concerned, there's really nothing wrong with splinting the patient and having them follow up. It's not overly conservative if somebody checks them within a couple of days. How about some closing thoughts from our editor-in-chief?
I agree with all of the above of everything you just said. Risks are kind of our ortho bread and butter. We see a ton of them in urgent care, and we should really be experts at this. I don't think history should tell you what the injury is 90% of the time before you even do your physical exam or your x-ray. Knowing how the patient fell or knowing how the patient injured their wrist is going to tell you what you should be suspicious of 90% of the time. And you can use that info to really predict what it would be. And then if your exam and your x-ray don't fit, then you want to rethink it, reevaluate, or refer it. We don't want to send things to the ED unless it's necessary. But if you have to, don't wait. Just go ahead and do it. Don't mess around with, I don't know if I should do this or not. If you think that there's any neurovascular compromise or you think that that might be a little more displaced than we should be handling, then please just go ahead and send it to the ED. And then make those relationships with the ortho colleagues. You can refer, you can call, you can consult if you have that relationship. One of my previous jobs, the orthopedic group, they had an on-call PA 24/7, and they gave us that cell phone number for that PA, and you could text them pictures of x-rays and you could say, hey, should I send this now? Or is it good to wait until tomorrow? And that was available to us 24/7. So if you can set anything up with your ortho colleagues or within your health system, if you're in a health system, or even the ortho guy up the street, that might be a good thing to do in advance. Anything else, Joe?
No.
All right. So that wraps up this edition of Urgentology. Next month is, well, not just sure net. We're not sure what net month is, but I'm sure it's going to be a great topic. I have some things in the pike here where we got diverticulitis coming up, acute diverticulitis, returning traveler, which is turning out to be a really interesting and I'll also say entertaining episode. And I know someone is doing ocular injuries and
Just finished.
with some really good pictures. And then yours truly is doing back pain. So that's in the works too. So stay tuned for all of those. We want to thank you for listening and I hope you have a great month. And we'll see you next time on the Urgentology podcast.
Take care, everyone. Bye-bye.
All right. Bye-bye. I want to thank everybody for listening to this month's evidence-based urgentology podcast. Just a reminder that subscribers can go to evmedicine.net and read the full issue if you want more information, if you haven't already.
And if you're not a subscriber, head to the site, that's evmedicine.net, to check out what they have. If you subscribe, you'll get access to the article, as well as future articles and the whole archive of all past issues.
Look forward to seeing you there.